Good afternoon and welcome to our Oncology Lecture Series. I am Dr. Galit Hakim, Assistant Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health. It is my pleasure to welcome all of you to this informative presentation. I would like to extend warm greetings to our friends across Latin America, the Caribbean, and everyone joining us today. During this interactive presentation, you will have the ability to ask questions via the Q&A feature located on the bottom of your screen. I will be your moderator for today's lecture. This afternoon, I have the distinct pleasure of introducing Dr. Manuel Ozambela. His presentation is titled Focal Therapy in Prostate Cancer. Dr. Ozambela is a urological surgical oncologist at Baptist Health Miami Cancer Institute. He specializes in the treatment of cancer that arises from the genitourinary system, urinary and reproductive systems, of course, including kidney, bladder, prostate, testicular, and penile cancers. Dr. Ozambela earned his medical degree from Harvard Medical School in Boston, Massachusetts. He completed his urological surgery residency in Harvard Urology program at Brigham and Women's Hospital. During his residency, he received both the Exceptional Resident Award and the Award in Academic Excellence for his outstanding clinical performance and academic achievements. Prior to joining Baptist Health, Dr. Ozambela completed his fellowship in urology oncology at the University of Texas MD Anderson Cancer Center. During the fellowship, he worked with multidisciplinary groups of researchers to study rare and aggressive kidney tumors with the goal of identifying novel treatment options. Dr. Ozambela has authored multiple scientific abstract manuscripts, book chapters, and various topics in urology and oncology. He is a member of the Society of Urological Oncology, the American Urological Association, and the American Association of Cancer Research. Throughout his research, Dr. Ozambela strives to identify new diagnostics and treatment options for genitourinary cancers, improve patient recovery after surgery, and enhance the quality of life of his patients. He is a phenomenal speaker at international and domestic venues, and we are thrilled to have him here today. Thank you so much, Dr. Ozambela. Please, let's give him a warm welcome, and the floor is yours, Doctor.
All right, well, thank you very much for that kind introduction. Let me go ahead and share my screen, and we can get started. Okay, so today we're going to talk about focal therapy for prostate cancer. I have no relevant financial disclosures or otherwise to share. So prostate cancer is very common, and it is the most common cancer diagnosed in men in the United States. About 1 in 8 men will be diagnosed during their lifetime, about 12% of all men. About 288,000 cases in 2023. It's the second leading cause of cancer-related death in men in the United States. About 1 in 40 men with a lifetime risk of about 2.4%. So this is a very prevalent disease that we treat in urology. And the landscape of prostate cancer has changed over the years. And a lot of it has to do with the ability for early detection, okay? So prior to the late 80s, early 90s, prior to the advent of PSA screening, the majority of men tended to present with prostate cancer once they had metastatic or advanced disease, because there was really very limited in terms of early detection. Following the introduction of PSA, though, we saw a couple of phenomena. Number one is all these men were sort of quickly diagnosed sort of at the same time as we introduced PSA screening, so we had this huge increase in incidence. But we also had a so-called stage migration. So if you look pre-PSA era, very few patients, about only less than a quarter of patients presented with low stage, low risk disease, and the vast majority were presenting with advanced disease or high risk disease. And so we've moved towards finding patients now at an earlier stage in their disease pathway. In addition, we've also observed an improvement in mortality during the course of this time in prostate cancer. So men are living longer with prostate cancer and doing better. And that really can be attributed to a combination of factors, including 1, early detection, but 2, better local treatments, in addition to better treatments for patients who are metastatic and in advanced settings. Let's see, next slide. Okay, so when we think about prostate cancer, though, it's not sort of one entity. There's and like most cancers, there's a risk stratification that is important. And we kind of tend to group these prostate cancers when they're localized into low risk, intermediate, or high risk disease. And this is going to be based on 3 criteria. Number 1 is what the patient's PSA is. Number 2 is what their clinical stage is. When you examine them, do they have palpable disease or non-palpable disease? And number 3, it's going to be the histology or the pathology on their prostate biopsy. And that can be broken down into different pathological grades. Gleason, it's based on what's called the Gleason score, okay? And we know that the natural history of untreated prostate cancer and what that looks like based on the risk stratification for patients. So this is a classic study that looks at men at different age ranges from early 50s to 70s that were diagnosed with prostate cancer and were followed. And what you observe is, so here in this bracket here, this would be Gleason 6. So Gleason 6 is what we call low risk disease. Gleason 7 intermediate, Gleason 8 plus, we consider it high risk disease. And what you observe is the red is prostate cancer mortality. Blue is just mortality from all cause, so from a different cause. And as you see in higher risk disease, if left untreated, and this is over a 20-year period, there's significant mortality from prostate cancer. And so I think that the main thing to highlight from here is that, and not all prostate cancer has the same predilection for lethality at diagnosis, and a lot of it's going to be driven by the biology of that cancer, and it's based on where they fall in this risk stratification, okay? So with prostate cancer, when it's localized, so this is patients who are not with metastatic disease, but a localized prostate cancer, our curative intent treatment options can be summarized here, okay? And usually what we talk about curative intent treatment for localized prostate cancer, we think about whole gland treatment, so treating the entire prostate. And this could be done, 1, with surgery, which is common. We do this a lot, and this is radical prostatectomy. Number 2 could be with radiation therapy, and leaning on a radiation oncologist, and they have different radiation therapy technologies and approaches. 3 could be with some kind of ablative therapy, so using ablation, but again, to treat the entire prostate. And we're going to go over a little bit about what I mean by ablation, or multimodal therapy, which is combining one of the above with medications such as androgen deprivation, androgen receptor inhibition, and using multiple therapeutic approaches together to try to eradicate and achieve cure for prostate cancer. Now, this approach of whole gland therapy and this understanding of different risk stratifications for prostate cancer has led to this sort of controversy of so-called overtreatment in prostate cancer. So, maybe some of you are familiar, in the last couple of decades, there was a push by certain preventative task force to unlist PSA screening as a recommended approach for prostate cancer screening. And the idea was there was a lot of patients in these low risk groups that have low morbidity and mortality from prostate cancer who are getting these whole gland radical treatments. And these treatments have consequences and side effects. So for surgery, for example, urinary incontinence and urinary leakage, it can be as high as 30% in some cohorts, as low as 2 to 3% in other cohorts. A lot of this is going to be surgeon dependent and center dependent and the experience of the surgeon. Erectile dysfunction can be a significant problem after surgery. Again, here there's a huge range if you look at the literature from places reporting erectile dysfunction as low as 3 to 5% to as high as 80% in some centers. Radiation therapy also has consequences related to erectile dysfunction, blood in the urine, hematuria, rectal bleeding, irritative voiding symptoms. So patients can sometimes have worse quality of life from urinary dysfunction. And over a long arc, there's some evidence that radiation therapy can lead to secondary cancers as well, such as bladder or rectal. And there's been this observation that you're looking at contemporary data that highlights that in low and some favorable intermediate risk disease or intermediate risk prostate cancers, that they can be safely observed with limited mortality over long periods of time. And so this has led to sort of trying to find ways to be able to gain cancer control, but limiting some of these quality of life issues. This is a very important study for us. This is the so-called PROTECT trial, and this is their 15-year outcome. And what they looked at in this trial, where they took men with a new diagnosis of localized prostate cancer. This is done in the United Kingdom. They were randomized to one of three treatment arms at diagnosis: either active monitoring, which I call active surveillance, surgery, radical prostatectomy, or they got radiation therapy. Okay. And what they observed was that at 15-year follow-up, there was absolutely no difference in cancer-specific mortality. In other words, the patients with similar prostate cancer characteristics, low or favorable intermediate risk at the beginning of the trial, if they were on surveillance, they lived just as long as the patients who had surgery or radiation therapy. And so over time, we've been doing more and more active monitoring for patients with low and intermediate risk disease. Okay. Now, some secondary outcomes to keep in mind in this study, that the patients who went on active surveillance, this is the purple graph. Now, these patients did have, over the span of the study, a higher clinical progression compared to those that had primary treatment. They also had a higher risk of needing systemic therapy with androgen deprivation therapy. And finally, there was an increase in metastasis. So these patients were more likely to develop metastatic disease. There's small numbers, and really this was driven mostly by patients who fell in that intermediate risk category, not the low risk category. So we're being less aggressive with these low risk tumors, with these intermediate risk tumors, but there are some disadvantages to this active monitoring that people still worry about. One, like I mentioned, there's a chance of missing the opportunity for cure in these patients. Once they progress to metastatic disease, prostate cancer is no longer curable. In some cases, men might be understaged. In other words, you think that they're low risk or low intermediate risk, favorable intermediate, but they harbor some more advanced disease. There was a sampling error on biopsy, et cetera. So you might miss patients who probably need treatment sooner. Three, there is a risk of progression that I described above. And then there's patient anxiety. A lot of patients, don't like the idea that they have this prostate cancer. You can try to reassure them, like, listen, you're going to live a long time. You're going to be fine. This is a slow moving target, but there's a lot of anxiety. And then the last part that I highlight here is that more than 50% of patients who start on surveillance eventually will need radical treatment during the follow-up. In other words, maybe they start on surveillance, but in the next 5 to 10 years, they end up needing radiation or surgery because their cancer is progressing. So I kind of think of this strategy as not a pure observation, but really a deferred treatment strategy. In other words, you might not need treatment now, but we're going to keep an eye on you, and you might need treatment eventually. So we're kind of in this conundrum where you have patients who sort of fall in between areas where, maybe active surveillance makes sense for them, but there's some concern that they may progress, but radical treatment seems too radical and there's a lot of side effects. And so this sort of spawned this idea of utilizing what we're going to call focal therapy in prostate cancer. So what is focal therapy? Focal therapy, you can think of it as treating significant cancer in a way that preserves the prostate tissue and minimizes side effects. Okay, so our goal here is going to be controlling cancer that has the ability to cause morbidity and mortality while preserving as much healthy tissue as possible. And this idea of organ-sparing surgery is not new. Okay, we think about this in breast cancer. Women undergo lumpectomies and in select cases and try to avoid radical surgeries when they can. For kidney cancer, which I also treat, patients with small, low-stage tumors, we don't remove the entire kidney, we just remove the area that's affected. Bladder cancer, the same thing. Penile cancer, thyroid, lung. So overall, in surgical oncology from various organ organ sites, we've been moving more and more towards organ-sparing cancer operations, organ-sparing approaches. But this, prior to recently, has not been adopted or used in prostate cancer. So, our goal with focal therapy, again, it's striking this balance where we can have good cancer control, but also preserve quality of life and function. Okay. So some definitions, as we talk through, the next section, ablation. When I say ablation, what I'm referring to is the in situ destruction of tissue in the prostate. And then, I talk about whole gland, partial, or focal ablations. Whole gland, I'm referring to the entire prostate up to the capsule being treated, whereas in partial or subtotal gland ablations, we're going to spare at least one neurovascular bundle, and I'll describe what that is. Or focal therapy, which is an even more restrictive procedure where we use image guidance to try to ablate about a quarter of the prostate, focusing just on the lesion and sparing both neurovascular bundles in the process. So again, here, what do we mean? So these are a couple examples. Imagine this cartoon here is the prostate. These little red circles are going to represent the neurovascular bundles. The neurovascular bundles, this is structures that run posterior lateral to the prostate and are what are responsible in great part for erectile function. And so here we have in A and B, we have examples of a partial ablation where we're preserving one neurovascular bundle, but we're covering the remaining part of the prostate in our ablation zone. And then in panel C, this is more what we mean by a focal ablation. If we can identify a focal lesion that's driving the prostate cancer biology, can we just ablate that tumor and preserve the remaining prostate tissue? So in terms of ablation, there are many ways to skin a cat, and there are many different technologies available to us. And I sort of break them down sort of generically into thermal ablation technologies and non-thermal ablation technologies. So thermal, this is going to have hot or cold features. So hot is going to be high intensity focused ultrasound. And I put a star here because I'm going to talk a little bit more about this in more detail. So this has been around for a while and has a lot of data surrounding it. There's focal laser ablation that uses heat as well. For cold, there's cryoablation using probes that create ice balls that can destroy tissue. And then non-thermal ablation, we have something I'm going to talk about today, NanoKnife, which is a irreversible electroporation modality, which is non-thermal. There's photodynamic therapy, and then there's focal radiation therapy, which I'm not going to go into, but that are also options. Okay. So in this table just sort of describes various different ablation technologies, and we'll, like I said, we'll focus on HIFU and IRE, which is NanoKnife today. The biggest experience with focal and ablation has been with cryo and HIFU, and IRE is a much newer technology. It's been around for a long time, but more recently is gaining traction in the treatment of prostate cancer. So what is the rationale for focal therapy and partial gland ablation? So in order for this to make sense, we have to understand that not every patient can have a focal therapy, right? Prostate cancer can be either unifocal or multifocal. Most prostate cancer is going to be multifocal. What I mean by that is there's going to be more than one tumor focus within the prostate gland. But we know that based on radical prostatectomy and pathology studies that, depending on the series you look at, between 13 and 38% of patients will have a unifocal cancer in their prostate once the prostate's removed, okay? And about approximately half of patients may have a unilateral disease. So disease is only on either the left or the right. So here we have a picture, for example, this is a histopathology slides, and you can see here where we outline, this is where the cancer is. So this would be, an example of a unilateral. So it's just on one side of the gland, not the other, and unifocal in the sense that it's just sort of one tumor. These are just different slices. So we're looking at different portions of the prostate. So in order for focal therapy to make sense, or partial gland ablation, we have to select for patients who have unifocal or unilateral disease, okay? So that's one big takeaway. and not every patient falls in that category. Number two is we have to understand that the biology of prostate cancer and its lethality and its ability to progress is typically driven, we believe, by an index lesion. So even in patients who have more than one lesion in the prostate, there's always going to be one so-called index lesion that drives the biology, and that's generally the lesion in the prostate that is the largest and the highest grade. And it may also be the lesion that is demonstrating signs of extraprostatic extension outside the capsule. Okay, and this top panel is a picture of an MRI, and you can see that this lesion that's being pointed to, this hypointense area, kind of correlates with the surgical specimen. And that leads us to our third point is we need an ability to identify index lesions, and we need an ability to identify patients who have unifocal versus bilateral disease. And this has been made possible by the advent of multi-parametric MRI. So MRI is very useful for us for planning purposes and for staging and understanding prostate cancer because we can see lesions much more clearly with more fidelity than with ultrasound alone. Okay, and here's a couple examples of I'll share. These are some MRI examples. So this is a prostate here. This is a transverse view. You can see the anatomy. This is the posterior zone back here. This is where the majority of prostate cancer tends to arise from. In the middle, you have what we call the transition zone. This is more where there's benign hypertrophy, BPH that men have. And this is a T2 weighted image. So multi-parametric MRI, we're going to look at T2 weighted imaging, which is going to be our anatomical imaging, and then we're going to have a couple other sequences, dynamic contrast enhancement, and also diffusion weighted image. So on T2 imaging, typically the lesion, the prostate cancer lesion, is going to be dark. It's going to be hypointense, and we can see one pretty clearly here in the left lateral mid prostate. And this is the same patient, but this is what we call diffusion weighted image. So generally, you see this white area corresponds with our previous slide, and this is areas where there's restricted diffusion of water. So MRI can look at hydrogen ions, it can look at the diffusion and movement of water within tissues and hydrogen within tissues, and in areas that are clinically significant prostate cancer live, the cancer cells, that tissue is more compact, tight, and it restricts the diffusion of water. And so usually this will be highlighted in diffusion weighted imaging. Okay, here's a separate example, and in this case, you see that the trichum is down here, and you can see that these tumors are posterior. And then in this is just an example, a different one. This is a tumor that's anterior. So the rectum's down here. This is an anterior tumor, and location is going to have implications for what focal technologies we tend to utilize. Okay. This is an ADC map, so it's diffusion weighted image, but it's sort of inverse. So the places with poor diffusion show up black in this ADC map. Okay. So what's our initial assessment for focal therapy? We have to, like I said, we have to select patients quite well to be successful here, and so we have pretty strict criteria for who is a candidate for focal therapy. So generally, it's going to be patients who have clinically significant prostate cancer on a biopsy, okay? And that means that when we do our biopsies, that they fall into that intermediate risk category at least, okay? If they're in low risk category with low grade cancer, those patients we really want to observe. We don't want to be aggressive and do treatments. But in that favorable intermediate risk category, with Gleason scores up to 4+3, these patients can be appropriate. We want to select patients who we identify to have either unilateral or unifocal disease, and we do this with imaging, but also with our biopsies. When we biopsy the prostate, we're going to biopsy any areas that appears significant or suspicious on our imaging, and we're going to also do systematic template biopsies to assess contralateral side of the prostate and other areas. Okay, and then we generally want to pick patients where their PSA is less than 10. And we'll explain a little bit more of that in a second. And then once we've identified a patient that fits our criteria, that they could be a candidate for focal therapy, then we need to do our planning. And we need a diagnostic quality multi-parametric MRI, and we're going to really focus on that lesion and does it have favorable characteristics. So things I look at, is a lesion close to the apex of the prostate? And why might that be an issue? We'll go into that. Is it at the extreme base near the bladder neck? Is the lesion posterior or anterior? That's going to have some ramifications. And can we clearly see it on MRI? So these are going to be what we're going to use for diagnostic and treatment planning. Okay. And in the selection criteria for focal therapy has evolved over the years as we have more technology and more data. And this is just sort of an example of different papers that have sort of put forward criteria. And more recently, these folks kind of agree with us: localized unifocal disease, PSA less than 10, grade group 2. So that falls into that intermediate risk bucket. Okay. And then again, and we're going to talk a little bit about this, but posterior versus anterior. Posterior tumors in our institution, we tend to often use HIFU, high intensity focused ultrasound. For anterior tumors, we rely more on needle-based therapies, that is cryo or IRE, that NanoKnife technology where we place needles into the tumor, and this is more successful for our anterior tumors, and we'll describe why in a few minutes. Okay. Let's hone in a little bit. So what is high intensity focused ultrasound? Okay. So high intensity focused ultrasound is going to be one of our thermal ablation technologies. An ultrasound probe is introduced in the rectum, and once in the rectum, it's going to emit focused ultrasound to a specific point, and it's going to create a quick rise in temperature and inducing an intense heat reaction, and it's going to create immediate coagulation and necrosis of that area. So you'll be able to ablate tissue, and you can ablate a fair amount of tissue fairly quickly. And if you look here in the bottom left, you can see this as an example. Like once the tissue is removed, you have a very sharp demarcation. So on the left side, you see healthy, untreated tissue, and then on the right side, you see the ablated tissue, which has been basically replaced with fibrosis. Okay. Again, generally, we're going to rely heavily on our imaging. Here's an example where we see an MRI positive lesion here. This is the left posterior aspect of the prostate, and then the bottom picture kind of is an example of what things look like once we're in treatment. Where we are able to then identify the lesion on ultrasound, and then we bracket our lesion, and the ablation is delivered to that area, sparing the remaining part of the prostate, including the neurovascular bundle, which is going to be out here laterally on the ipsilateral side, and the neurovascular bundle on the contralateral side. And the ultrasound that is used during this is very high fidelity. I mean, you could really see the pulsation of the neurovascular bundle. It's quite neat. How is this actually done? This has to be done in the operating room under anesthesia with the patient totally paralyzed, because we don't want them to move while the ablation is happening to avoid injury. The patient's laying down in the lateral position. This is the ultrasound probe. It's introduced into the rectum, and then this is what we see. Okay, the transducer is here, and it's going to transmit our focused ultrasound to the prostate, to the area that you've bracketed, and we're going to leave about a 4 millimeter window away from the rectal wall. Okay, in order to preserve the rectal wall, because we don't want any injury to the rectal wall. The transducer itself, you see all this black, it's actually sitting inside a cooled fluid that keeps the rectal wall cool, and it's constantly cooling it to avoid injury. And some of the limitations here are going to be, number one, anterior lesions can be difficult to reach, and especially in larger prostates. Number two is this is causing heat and coagulation and necrosis and fibrosis of the tissue that is treating. So if you're very near the apex of the prostate, you're going to be near the sphincter mechanism, you're going to be near the urethra, and you have to be very careful. Generally, we want to leave space between the beginning of our ablation zone and the apex, because you can get scarring, urinary strictures, and urinary retention, etc. So we're limited in our ability to treat very close to the apex with this technology. The same thing with the urethra. We don't want to use this on the urethra, so we have to avoid the urethra and leave some space between our ablation or urethra because, again, stricture, retention, etc. And in terms of the functional outcomes, they're quite good. This is one of the early studies looking at HIFU. This is a study from 2012 by Ahmed and colleagues. 41 patients with this was just a 12-month follow-up. And what they observed was that about 63% of these patients were intermediate risk. Up to 10% here were high risk. So this has been studied in some high-risk patients. But some key takeaways: 89% of patients had spontaneous erections at 12 months. Okay, and 100% were dry. No one had incontinence. There was a post-study biopsy that was done, and what they observed was that about 8% of patients on that biopsy did have some clinically significant prostate cancer remaining, which suggests that about 98% of the time we're able to control and eliminate the cancer using this technology. What about oncologic outcomes? This is a more recent study, 5-year follow-up looking at HIFU in localized prostate cancer. This was 625 patients. It was a prospective study, 5-year follow-up. Again, here the majority of patients were intermediate risk, and what they observed was that the 5-year failure-free survival was 88%. And that's pretty good. So, what I mean by failure, it's a patient counts it as failing therapy if they had radical treatments, meaning surgery or radiation, whole gland treatment. They had systemic therapy, in other words, they've developed metastatic disease or something and required androgen deprivation, or they developed metastasis or death. So any of those were considered treatment failures. So their failure-free survival was 88% at 5 years. Okay. And when you look at who failed, sort of as you expect, patients with higher Gleason scores or higher risk disease were more likely to have a treatment failure. And also patients with higher PSA. So PSA less than 10 was did better than PSA greater than 10. So this is why we sort of have limited our patient selection to patients with PSA less than 10 if we can. Okay. And if you look at generally, what are the complications that we're seeing after these procedures? The one I see the most is urinary retention. So after these procedures, we do the ablation. Generally, patients will have a Foley catheter in place, and that catheter usually stays for about 7 to 10 days. And the biggest thing we see is retention. When the catheter comes out, the patient might go into retention. Less than 27%, but it's probably closer to at least 5% in our experience. And again, that has to do with especially in HIFU patients, there's some swelling that occurs, and a lot of these men might be on alpha blockers or something else, and so retention can be common. Urinary tract infection is seen periodically. I think a lot of this just are their catheter-associated UTIs. Patient goes into retention, needs a catheter for longer periods of time, and they may develop infection. A urinary fistula is quite rare, and it's reported, but it's generally seen in patients who have these therapies not for primary treatment of their prostate cancer, but for salvage treatments. I'm not really going to go too much into that whole area, but some of these focal therapies can be utilized after a patient first receives a radiation whole gland treatment and has a radiation failure, and sometimes we're using these focal therapies in that setting. And those patients, as you can imagine, radiation plus ablation have a higher chance of developing fistulas, but in the primary setting, it's very rare. And lastly, urinary incontinence is exceedingly uncommon in this scenario, but it has been reported. So now we'll move on to the next portion here, and I'm going to talk a little bit about NanoKnife. This is a non-thermal technology for focal therapy that we can use in settings where focal is appropriate, but HIFU, has some limitations. And so this is a nice complementary approach. So what is irreversible electroporation? Define it as a focal non-thermal ablative technology. It's going to use high voltage low energy direct electrical pulses to permanently open pores in the cell membrane to induce death of the cells while preserving the integrity of the extracellular collagen and matrix. Okay, and so the way I've heard it described, which I thought was a good way, is it generates basically a light scar versus that intense fibrotic reaction that you get from a thermal technology. You're going to get a light scar, so it's a little bit more of a gentle technology. And so this is, just a cartoon up here. If you think of a cell with an intact cell membrane, as you know, the cell membrane has to keep a potential, a cell membrane potential to sort of keep, solutes, flowing in and out in a controlled fashion. Once you expose the cell to a high voltage direct current, it's going to wreak havoc on that membrane potential, and it's going to create these micropores in the cell membrane, which is going to lose it's going to create basically make the cell permeable, and as that happens, the cell basically begins to apoptose and die. And this can be actually seen when under electron microscopy. So here's some interesting examples of a couple of papers that have been published looking at this. So on the top panel, we have normal liver cells, under 20,000 X magnification using electron microscopy. These cells are exposed to IRE, and then you can see the formation of these nanopores. Okay, and then here is another example, and you can see this is time dependent in milliseconds to seconds, but very quickly, how you can start seeing little pores forming on the cell membrane, which then basically leads to cell death. Okay, and so this one it's done a little differently. Again, this is done in the operating room, under anesthesia. The patient in this case is in a dorsal lithotomy position. An ultrasound probe does go into the rectum, and that's what we do use for our live imaging. We also use basically MRI fusion technology. So we're able to take our MRI that we did for preoperative planning, combine it with our ultrasound, so we can successfully target the lesion in the prostate. But the probes that deliver the treatment actually, which look like this little blue thing here, they go through the perineum directly into the gland. And what the goal is to bracket the index lesion that you want to treat with probes, and then once that's done, you're able to generate an electric current between the probes. Okay, and that's what causes that's what causes the efficacy of this technology. So here's an example. Here you have our prostate. This is a transverse ultrasound, and you can see these little white dots here. These are us bracketing the area. Okay, and then this is a pathology specimen showing the ablation zone. Okay, and then there's another example here that used 4 probes. Here again, you create an ablation zone, and it correlates with our imaging. This is an interesting sort of description of what's happening. So here's one probe, here's a second probe. Generally, we have to place these at least no closer than 1.5 centimeters. And the ablation zone is going to extend about 5 millimeters distal to the tip of our probe and about 5 millimeters lateral. And so you can see here as it creates this sort of ablation zone around from where we're bracketing. So what are the advantages of IRE? Number one is it's an outpatient procedure similar to HIFU. It's also an outpatient procedure. A reliable in-field ablation. So the area that we bracket gets treated quite nicely. And relative to a HIFU or cryo or other technologies, it causes less collateral damage. Okay, so you're able to really maintain the prostatic structure a little bit, and it can be used in those sensitive areas because it causes the cells to apoptose and necrose, but it does not cause destruction of the extracellular matrix, and it preserves blood vessels. So if you were to apply HIFU to a blood vessel, it's going to basically cauterize it and heat it up and destroy it. Whereas if you bracket a blood vessel with IRE, the collagen and extracellular matrix that makes up the adventitia, et cetera, that's not going to get disrupted. And so after you get apoptosis and death of the cellular components, and that'll get replaced, and so you end up having a more sort of gentle ablation. And so that means that we can use IRE in the apex where we can't really use HIFU, and we can do that well. And then if the lesions are close to the urethra, where we also don't want to use, ablative thermal ablative technologies, we can use this near urethra with less collateral damage. And then here, that last point, salvage procedures are made easy. What I mean by that is, anytime you give a primary treatment, you always have to think about, if that treatment fails, what do you do next? In cases of ablation or radiation, if you have to go and do surgery after that primary treatment, it can often be more challenging with more complications, et cetera. And so IRE has been shown to cause less of that thermal sort of collateral damage. And so going into doing a salvage prostatectomy or salvage surgery can be a lot easier with better outcomes. And so, the IRE, again, it's been around for a while. It's been used in other disease sites, liver, kidney, et cetera. Newer to the prostate, but we do have some functional outcome data. And basically, again, urinary retention 8 to 9% is fairly low. Erectile dysfunction 3 to 7%. Again, very, very good outcomes, and very, very low 0 to 1% stress urinary incontinence. And in terms of our oncologic outcomes in the available prospective studies for IRE, we have a disease-free survival of 78 to 89%. Now, there is a retreatment rate of about 10%. So the other beauty of this is if you do have a treatment failure, you can often salvage that treatment failure with a repeat ablation. You don't necessarily always have to move on to a more whole gland or radical treatment. So there is a retreatment rate of about 10% here. And then these last two in-field failures. So that's been estimated between 3 and 17%. So that is the area that you bracketed, that you treated, going back, if you biopsy that area, how many patients are still having residual disease there. Could be as high as about, 1/5. And out of field failure. So patients developing clinically significant cancer outside of your area of ablation, that can be as high as, again, 5 to 20%. Okay. So, as we wrap up here, when at the end, all these treatment decisions in prostate cancer kind of fall in. Same with even prostate cancer screening. It comes down to shared decision making, and really talking to your patients and understanding the advantages and disadvantages of focal approaches. Advantages, a lot of them have to do with better functional outcomes, very low incontinence rates, very high natural erections after treatment. It's an outpatient procedure. They may just need to have a catheter for about a week. Most patients do quite well. Some of the disadvantages to highlight is that about a quarter of patients will need probably another salvage procedure, another focal procedure potentially in the next 5 years. So it's not going to be as good as at eradicating all disease as a more radical treatment. About 7% of patients who undergo some kind of focal will eventually, in the next 5 years, move on to radical treatment, needing whole gland treatment, et cetera. And if you're going to undergo focal therapy, you can't just get focal therapy and disappear. You do have to be committed to being followed closely with PSAs, MRIs, and potential rebiopsies. And for thermal ablative specifically, you have to keep in mind that if you have a treatment failure, sometimes surgery after an ablation could be a little bit more challenging. However, with more focal ablation versus partial gland ablations where you're doing bigger zones, patients can still do pretty well. So in conclusion, focal therapy is an appropriate treatment for select patients with MRI visible intermediate risk prostate cancer. And the key here is all about patient selection, okay? The second point I would make is that it's very important to have good pre-procedure planning with good diagnostic multiparametric MRI, good biopsies of the suspected lesion, plus systematic biopsies to really map out where the cancer is in the prostate gland. Really, it comes down to a patient-focused approach where we have careful discussions about the pros and cons of focal therapy versus surveillance versus more radical therapy. And oftentimes we have to kind of focus on what the patient's goals are, and what's the most important thing to the patient when we're deciding on this. And then ultimately, which I think is true in general, we want to use the right tool for the right job. So not every patient, like I said, we don't just give focal to everyone, but for the right patient, I think this is really a good option. So with that, that sort of concludes my chats. Thank you for your attention, and I'm happy to take any questions that may come up.
Thank you so much, Dr. Ozambela. What a phenomenal presentation, and I love the way that you just recapitulated some of the most important technologies that we have at our disposal. It is kind of alarming that it is the second cause of mortality in men, and you highlighted that very clearly. And obviously, thanks to the early detection and the management of those patients at a very early stage, we have been able to actually change the paradigm in the way we have set up treatment plans for patients, and obviously outcomes and the quality of life for these patients. Not long ago, patients were submitted to very radical ways of actually treating this disease with dire consequences. And that obviously has catapulted into what we know now as the fear-mongering type of approach to actually identifying early disease in prostate. So just to make certain that we are again highlighting how important the PSA continues to be, despite the controversy several years ago, you're still using PSA more than 10 when you are qualifying these patients in your criteria. So we want to make sure that we continue, especially to our physician students, to understand that PSA, together with those checkups that the well-man receives, will definitely contribute to the outcomes. Dr. Ozambela, you mentioned two of the most recent technologies, obviously most recent for some countries. We have been using HIFU and NanoKnife, as you stated, in different type organ diseases, but now more so in prostate. What a wonderful thing to actually have at your disposal in your armamentarium at the moment that you're discussing, as you stated at the end, what is that the patient needs and wants at the time of diagnosing and planning treatment. I love the fact that NanoKnife gives you the ability of actually saying to the man, listen, with NanoKnife, you're going to spare a lot of the issues that you will potentially have perhaps with HIFU and other. In your experience, which one of these technologies has been the most successful in actually eliminating some of the fear that man has at the moment of planning the treatment for prostate cancer?
Yeah, no, I think that's a great question, and they're quite different technologies, and as I sort of mentioned, you want to use the right tool for the right setting, and so we've had good functional outcomes in both for both of these treatment strategies for both HIFU and NanoKnife. I will say, just in our own experience, and I think this is mirrored in the literature, is that with NanoKnife, one of the because NanoKnife is very much a very focal approach. So these patients are even more selective because we have to have a very clear MRI visible lesion. Where with HIFU, we can often we see the lesion, our brackets, we can get a little bit more of a margin, and so with NanoKnife, we do have slightly higher recurrence rates. However, the upside, like I mentioned, is we always have the ability to do a second ablation if we do have a recurrence. And so I would say that the functional outcomes have been very good for both of these. The recurrence rates have been a little bit higher with NanoKnife, I think, because of that challenge of really needing a really high quality MRI to bracket these lesions, and it could be a little bit more tricky because with HIFU we have a little bit more leeway where we can do more of a hemi-ablation or a partial ablation. We can extend the treatment zone a little bit. And like I said, I think the game changer for NanoKnife has been for those apical lesions, lesions very close to the urethra, where you don't want to use a lot of thermal energy that can cause strictures, etc. That's where it's been very successful. And I would say about, probably about 20% of patients, maybe less than 20% of patients are patients who I would consider good candidates for focal. So the workhorse is still, going to be active surveillance for the low risk patients and surgery or radiation for higher risk patients with multifocal disease that aren't amenable to focal therapies. But definitely, I think one of the advantages of our institution is that we have the ability to kind of offer the full spectrum of options. And I think you highlighted nicely, there was a lot of fear about PSA screening, and the fear came because a lot of patients were being overtreated. They had low risk disease and they were being treated as if though they had high risk aggressive disease. And so now we understand that if we risk stratify patients appropriately, we surveil the ones that are appropriate for surveillance, and we treat aggressively the ones that need aggressive treatments, that patients do better, right? They live longer, they have better long-term outcomes. And we're not kind of getting into the trouble of, all these men with incontinence and erectile dysfunction that would have never died from the prostate cancer in the first place. So I think understanding the biology of the disease better, having the full spectrum of options available for patients is one of the values that, institutions like ours have, to really, span the gamut in terms of what can be done.
Indeed, and again, it's never tiring to actually repeat, especially to our partners, that understanding the biology, be it in a breast or be it in a prostate, is the way to go. This is the way that the new movement in oncological treatment should be, and it is done. The way we do it at MCI, it's perhaps one of the most innovative ways, which is you have an interdisciplinary approach. You even consult with radio oncologists, you consult with the medical oncologist, if that is the case. So everybody has perhaps a guided opinion based on evidence and scientific evidence. And you did mention the fact that you have all these tools, but it has to be based on outcomes, and it has to be for the sole purpose of protecting the patient. Now, the other issue that man has is obviously the loss of erection. That has always been one of the biggest perhaps conundrums for men. Oh my goodness, do I go with a full prostatectomy, or do I just get into a salvage type treatment? You did mention that in HIFU it is 89% in the first 12 months, and then 100% thereafter. So that the outcome is absolutely fantastic in HIFU. Is it the same for NanoKnife as well?
Yeah, very similar in terms of incontinence is almost 0% for NanoKnife, and erectile dysfunction is very, very low. Less than 5% really, and that's because we're really able to spare the neurovascular structures that provide erections for the patients. I tell patients though that one of the confounders is that as men get older, they have other things unrelated to prostate that can cause erectile dysfunction, heart disease, diabetes. And so if you just, without treatment, probably over time, erectile dysfunction is going to pop up anyway. So there's a little bit of a confounder there. And then I also like to kind of emphasize to men when I talk to them is that we have very good ways to help you get erections. So, even though, some of these treatments can affect erections, we have a multitude of strategies for sexual function recovery, and that could be medication, whether oral medications, injection therapies, more sort of physical therapy type things with vacuum devices, And then there's ultimately always penile prosthesis surgery, which is kind of the most extreme version. But I always try to emphasize that there's always ways to help patients regain their sexual function and their sexual intimacy with their partners and wives.
Absolutely. There is a question from Costa Rica, and it says, how often is a follow-up for patients with focal treatment? How often do you think you should be seeing these patients?
That's a great question. And the interesting aspect of this is there's not very super clear guidelines in terms of exactly what the treatment strategy. But in general, these patients need repeat imaging, PSAs, and usually a repeat biopsy. So we generally have been doing PSA every 3 months, checking in with them, seeing how their symptoms are, and then we'll typically do a repeat MRI at either 6 months or 12 months and a repeat biopsy if that MRI looks suspicious. So in our practice, in general, PSAs every 3 months for the first year. We usually see the PSA decline and then just kind of stay flat. And then we get an MRI at 12 months and then often a biopsy after that to confirm that there's no treatment failure.
Dr. Ana Laura Sandoval from Costa Rica is wondering why the treatment for the needle in IRE is best for the anterior type tumors. Is it has to do with the histology, or is it anatomical decisions?
Yeah, that's a great question. It has a lot to do with anatomy. So remember that with HIFU, and that's going to be, so I can kind of split it into transrectal approaches. So HIFU, we're putting the device in the rectum, the ultrasound waves, so they go from the rectum through the rectal wall all the way into the prostate. So if it's anterior, it's going to be further away from our treating device. And so we have less, sometimes it's harder to get a controlled burn in that area. With the needle-based approaches, the needle's going directly into where you're treating. And so other needle-based approaches, for example, cryotherapy, where instead of using electrical currents, we're using ice, basically cold. These bypass that limitation. So it's less about the histology and more about the anatomical location and the limitations of the technology. So anterior tumors, we tend to use needle-based approaches. Posterior tumors, HIFU works beautifully.
Mm-hmm. And in your experience, how often do you actually provide erectile treatment for erectile dysfunction?
In patients who undergo focal, it's not that often. I would say maybe 10%, whereas that will eventually get either oral therapies, etc., but well less than 10%. After other treatments, radiation, surgery, it's going to be closer to 50%. Now, with surgery, radical treatments, usually erectile function improves over the course of 12 months. What we see similarly with these focal technologies, erectile function will dip a little bit for the first month, but then it recovers really quickly. And I would say less than 10% will need any kind of treatment. That being said, a lot of patients, by the time they come to see us, they're already taking Cialis, they're already taking sildenafil, so they already have some baseline sexual dysfunction when they see us. And so the number one predictor of post-procedure sexual function and erectile function is going to be, how were you before? If you already started off needing help, then it's not going to be better after treatment, right?
Okay, is there a comparison between this particular treatments that you have talked about in brachytherapy, focalized brachytherapy?
Yeah, that's a great question. I haven't seen any head-to-head comparisons between brachy, focal brachy, and these modalities. And I don't have much experience with focal brachy. Generally, that's one of our radiation oncologists. Has interest in focal brachy and does that. But I want to say that they're fairly similar. I think with focal brachy, it's a radiation-based approach. I think in those patients, they often will have they'll do worse from a functional outcome perspective. But I want to say that like from a cancer outcome perspective, it's very similar. But yeah, it's a great question. I have not seen focal brachy is not very commonly utilized. I would say it's very rare. The vast majority of patients getting focal, it's going to be HIFU, IRE, cryo, something like this. And there haven't been really any head-to-head comparisons that I'm aware of.
One last question, and this comes via text from Dominican Republic. Dr. Fermin is wondering, do you have any experience with Resume water vapor? I believe this is for BPH. I don't know what your thoughts about Resume is.
Yeah, it's a great question. So it's for BPH. It does not treat prostate cancer. I have some experience. We used it during my training, and it tends to be a pretty well tolerated procedure. What this procedure does is it's done transurethral, so you put a scope in the urethra into the prostatic urethra, and a needle goes into the prostate. And what it's able to do is basically create this water vapor, this convection that causes necrosis and involution of the tissue. So for BPH, it's a very good procedure. Can be done in the office as an outpatient. Patients tolerate it fairly well. They do have a lot of because you're not removing any tissue, you're basically waiting for the tissue to kind of get smaller and kind of die off. And so for the first like 3 weeks after resume treatment, patients can have a lot of symptoms as that tissue's kind of getting smaller. And oftentimes they need to keep a catheter for a week or so before they can pee on their own. But yeah, it's being used more commonly, and there's a lot of different BPH procedures out there nowadays.
Well, Dr. Ozambela, we can keep you for another hour if you allow us, but we want to be considerate to you and to your time. And on behalf of our entire team at Baptist Health International, number one, I want to welcome you to our incredible hospital system. And obviously, we are thrilled to have you. And I would like to thank you also for your incredible and informative presentation today. And to all of you that participated and for your great questions and for attending. If you have additional questions about today's presentation, please feel free to email them to BHIWebinars@baptisthealth.net. That is BHIWebinars@baptisthealth.net. We will promise to make sure to forward those to Dr. Ozambela for him to elaborate, and we will forward that back to you. If you're interested in actually getting a consultation with Dr. Ozambela, please make sure to reach out to Baptist Health International. We will be more than happy to set you up with a consultation with him. And we look forward to seeing you again in our next oncology lecture series. We scheduled that for Wednesday, April 10th, 2024. Thank you so very much to all of you. And thank you, Dr. Ozambela, for your time.
Thank you, everyone. Enjoy the rest of your evening.
Thank you.